Imagine that you are in the emergency room at 0:05. The monitor alarms. You see ST segment elevation in the precordial leads. Your first instinct? Activate the cath lab? But wait. If you call this a STEMI, you might be sending a patient with pericarditis for an unnecessary procedure or worse, missing a life-threatening electrolyte imbalance. Today we are decoding the great mimics. We are going beyond pattern recognition to true clinical reasoning. Acute pericarditis, benign early repolarization syndrome, and ST elevation myocardial infarction are the ones which cause diagnostic dilemma in the emergency room. In acute pericarditis, there is diffuse concave ST elevation across almost all leads. There will be or may be PR segment depression, especially in lead 2, and PR elevation in AVR. In V6, if ST segment height is more than 25% of the T wave height, it is more likely pericarditis. In benign early repolarization, high concave upward, most prominent in V2 to V5. And look for the fish hook, that is the J notch at the end of the QRS complex. Unlike a STEMI, early repolarization patterns do not evolve over minutes or hours, but that takes time to recognize. You can't decide at the moment when you are suspecting STEMI and thinking of cath lab activation. Left ventricular hypertrophy often creates deep S waves in V1 to V3 and secondary ST elevation, which can look exactly like an anteroseptal STEMI. Look for the Sokolov line criteria, S in V1 plus R in V5, V6, more than 35 mm. Then there is a rule of discordance. In LVH, the ST segment and T wave should be discordant, pointing the opposite way to the main QRS. If the QRS is deeply negative, ST elevation is expected. But if you see concordant ST elevation, QRS and ST segment both pointing up, that's a real STEMI hiding on top of left ventricular hypertrophy. Though a new LBBB was thought of as a STEMI equivalent, many LBBBs are chronic. That's when the Scarboza criteria, which is considered as a gold standard in this situation. Concordant ST elevation, 1 or more millimeter in any lead, has a high specificity. Concordant ST depression, more than or equal to 1 millimeter in anterior leads. Or excessive discordant ST elevation, that's the modified Smith-Scarboza criteria, ST elevation by S wave ratio more than 0.25. That replaces the more than or equal to 5 mm discordant ST elevation Scarboza criteria. Never forget the metabolic mimics. Potassium shifts can cause pseudo-injury patterns. Widened QRS complexes that bleed into the T wave, creating a sine wave appearance or peak T waves. If you give thrombolytics to a patient who actually needs calcium gluconate and dialysis, the outcome is disastrous. Reciprocal change is probably the strongest evidence for a STEMI. If you see ST elevation in the inferior leads 2-3 AVF and ST depression in AVL, it is almost certainly a true myocardial infarction, not a mimic. But ST elevation in AVR and possibly V1 is an exception which can occur in pericarditis along with diffuse ST depression in other leads. That is because these leads are oriented to left ventricular cavity.